We have arrived at the special investigations segment of our whistle-stop tour of Gynae emergencies. Now we're going to look at the individual, we're going to look at them one by one. So in retained products of conception, what I'm going to do is I'm going to bring this a little bit closer so that you can see it more clearly. Let's get the light on there. Okay, so what you're seeing here is that is normal uterus, and there's a very thin endometrial lining. Okay, so that is what a normal uterus would look like. If you are talking about somebody who's got retained products of conception, you can see here, and I don't expect you to be able to interpret ultrasound findings in the absence of other clinical information, which is going to give you the diagnosis already. But this is just to help you conceptualize. So this uterus has definitely got something in it. And in the context of somebody who comes in who's bleeding and pregnant, that is retained products of conception until proved otherwise. Okay, so aside from the scan, oh, and please note these are the sites, the websites where I got the scans for attribution. So you're going to see the retained products on the scan. You're going to want to do a full blood count for one and potentially two reasons. One, you need to know what the hemoglobin is because this is a bleeding patient. And two, if she's septic, you might want to know, you're going to want to know what the white cell count is. You also potentially want to cross-match this patient if she's bleeding heavily and her vitals are compromised. If she's septic, she may also need to have a blood culture so that you know what drugs the bug is sensitive to. Okay, so that is retained products of conception. Now we're going to move on to ectopic pregnancy. So let's just get these out the way. And okay, so ectopics. Oh, let me do this for the... Okay. So I need to talk you through this, which I will, but let's just go through the principles of what you're going to see first. So you're going to see a uterus that is empty. So empty means there isn't a fetus in it. Okay, the endometrium might still be a little bit thickened because of the pregnancy hormones, but it doesn't have a fetus in it. Okay, you are going to see an adnexal mass. And I'm going to show you a picture of what I mean by that. You might see free fluid in the pelvis if the ectopic is ruptured. And on your FBC, you're obviously going to see a decreased HB if she has ruptured. And then you would also actually want to do a cross match. And I'm going to add that in right now, live and unedited. You would want to do a cross match for her. Okay. So let's have a look at the images. Try and get this in here for the camera. So this uterus isn't quite empty. It's got some endometrial tissue in it, but it doesn't have a fetus in it. Okay, so there's no fetus with any heartbeat in there that you can see. And also something that I wouldn't expect you to interpret, but the sonographer would be able to see, is there's a huge amount of free fluid here in the pouch of Douglas, which means she's ruptured. This is blood. So that ectopic has ruptured. So there is some material inside there, but your clinical picture with your pregnancy test and a lack of a fetus in the uterus shows you that it's an ectopic. With the addition of free fluid is even more convincing that it's an ectopic. Now there's another scan here that I'm going to bring up. I just want to bring the light to show you nicely. Here is a normal intrauterine pregnancy. So there, the sonographer will be able to see very clearly the features of a fetus. Here, you've got a uterus, and now this is a cross-section view. So you're looking at it, a cross-section, as if you're looking at it from the top. There is a little bit of endometrial thickening in the uterus itself. Can you see that? But here you can see what they call the donut sign. That is evidence of an endometrial... an ectopic pregnancy in the tube. So a uterus that is empty of a fetus, and there's something going on in the adnexum that is pathognomonic of an ectopic on a scan. But remember, you don't need the scan to make the decision, because your brilliant clinical acumen is going to be the thing that does it. Okay, now we're moving on to PID grade 3 and 4. What do we need for that? So a scan. All right, let's go through the principles, then I'll show you the scan. The scan, you are likely to see an adnexal mass, or possibly on both sides. An FBC, you would expect a normal or slightly decreased HB. You'd expect a raised white cell count. You would also want to do a blood culture for this woman when she spikes the temperature, so that you can try and make sure that you're targeting the right organism. So here's your scan. The best way to describe this situation is just, it's a mess. Okay, so what this is showing is areas of fluid collection in the ovary, right? Which is places that have been obstructed. So the normal sort of lubricating fluid from the tube isn't allowed to pass into the uterus. So that's kind of the beginning of a hydrosalpinx. And then you've got this grotty, denser material which is purulent in nature. So this is again something I would never, for example, put this in an OSCE and say what is the diagnosis. But this is what you would see if somebody has got a tuber-ovarian complex on the scan. Okay. So you'd see an adnexal mass, the uterus would be empty. You would want to do an FBC, particularly looking at the white cell count, and you'd want to do a blood culture. Some people would do inflammatory markers, some people wouldn't, but the white cell count is helpful as part of your differential. Okay, now moving on to our ovarian torsion with our very rare purple koala bear. Okay. So the scan is going to be the most important thing here. Now, before we look at the scan, I want you to just see what a torted ovary looks like. Okay, so that is an enlarged ovary. There's the ligament that is twisted over itself. There's got to be some kind of cyst thingy on there in order for this to have happened. Okay, there's not too much to see on this one, except that the ovary is enlarged, which I don't expect you to know, because I don't expect you to know how to interpret ultrasounds, but that is essentially translated into that. Here's another image which illustrates, so this is a huge simple cyst on the ovary. This ovary is quite radically enlarged, and I only know that because I look at scans all day, but this is a sitting duck for torsion. So this is a torted ovary, and whatever happens, whether they can save the ovary or not, they have to get rid of the cyst, otherwise it's just going to happen again. Okay, so your most important investigation for an ovarian torsion is a scan. Just a normal pelvic scan. Sometimes if they're not sure, there's a bit of equivocation, they might do an MRI, but it's normally just a scan. Okay, so before I end off this bit, I just want to focus yet again on this bit. We've done the special investigations right at the end of the series. See, we're a new day now, new bangle. Today I'm not even married because I was at work and coronavirus and infection control. So we've done it on a different day altogether, and it wasn't included in the whole clinical story of all the patients because these gynae emergencies are potentially life-threatening, and you are not necessarily going to have access to any of these special investigations, or you might not get the results back in time for this patient to actually survive. So it's important for you to use your clinical acumen to start a management plan, even in the absence of a nice, beautiful ultrasound or blood results, etc., because those kinds of delays contribute to killing patients. So you got to use your brains for this. Okay, finally, the next one is where I put everything together and we look at the whole chart and all the comparisons all together. And for that, I'm probably going to need more space. So we can say goodbye to our 4 patients who survived because they were managed despite the fact that we didn't have access to special investigations because we're on lockdown.